Good morning, dear colleagues. Today we will talk about tumors, epithelial tumors, and a cancer of the definite organ. This topic opened the big section of oncopathology, which you will study at the last weeks of this semester. Tumor, that is a pathological process characterized by the uncontrolled cell proliferation with the disturbance of cellular growth and differentiation due to change in cell genetic apparatus. Epidemiology of the tumor growth. In this year, about 1,080,000 new cases of the cancer will be diagnosed in the United States, and more than 500,000 of people will die from this disease. The rate of the new cancer cases is 442 per 100,000 men and women per year. The cancer mortality rate is 158 per 100,000 men and women per year. Cancer mortality is higher among the men than among the women. The most common cancer are breast cancer, lung, bronchial cancer, prostate cancer, colon and rectal cancer, malignant melanoma, bladder cancer, non-Hodgkin's lymphoma, kidney cancer, endometrial cancer, leukemia, pancreatic cancer, thyroid cancer, and the liver cancer. Etiology. There are a lot of factors which lead to the malignant transformation of the cells. It may be viruses, chemical and physical agents, hormonal imbalance, sex, age, diet, and of course heredity. Viruses. It may be DNA or RNA containing viruses. Now we know more than 150 types of the oncogenic virus. In this case, virus fused genome with the host cells, and the host cells, human cells, transform to the malignant cells. And we have the growth of the new tissue which has a lot of abnormal properties. The same for the chemical and physical agents, which all factors lead to the injury of the genetic apparatus of the cells, to mutation. Hormonal imbalance lead to increased proliferation of cells, and increased proliferation of course lead to increase of quantity of the mutation of cells, and the possibility of tumor growth is increased. The common cause of malignant growth is the insufficiency of the anti-blastoma resistant system, anti-tumorous defense system. And the main elements of this system is DNA repair enzymes, anti-oncogens, and natural killer cells. The following factors lead to the failure of the anti-blastoma resistant system. That is, intense carcinogenic effect, immunodeficiency states, lack of DNA repair enzymes, and the functions of anti-oncogens, for example, in a pigmented xeroderma. As mutation accumulates in the given cells, there is a progressive loss of regulation of the cell cycle, differentiation, and cell-to-cell adhesion and interaction. These changes are accompanied by the progressive abnormalities in morphology, appearance of the cells. Here you can see the etiological theories of carcinogenesis. It may be viral theory, physicochemical theory, disontogenic theory, and polyetiological theory. Viral theory is based on the properties of viruses which has oncogenic potential. Physicochemical, of course, it's associated with the injury of cells by the physical and chemical agents. This ontogenic theory is found in 19th century by Congan, and it's based on the possibility that the tumor grows from the embryonic cells, which detach from another cells of the embryo, and from these cells may grow tumor. Polytheological theory is based on the association of a lot of factors, maybe a virus and physical chemical agents, and maybe some other position. On this table you can see a lot of factors which lead to the cancer growth, and in different cancer these factors fuse together in different percentage. As you see, for the colorectal bowel cancer, the main factors which lead to the cancer growth, that is a lot of meat in your diet, and obesity, a lack of fiber also, and ionizing radiation, it's just 1.6% of risk. Classification. We are classified according to histogenesis all tumors into the 7 groups: epithelial tumors without specific localization, tumors of endocrine and exocrine glands and epithelial sheaths. It's both group about the epithelial tumors. Third group, mesenchymal tumors, then melanin forming tissue tumors, nervous tissue tumors, and the tumors from the brain meninges, and gemoblastosis, it's a tumor from the blood system like lymphomas and leukemias. And one separate group, it's teratomas. Tumors may grow de novo in the tissue, but more often it's grows from the precancerous conditions. What is it? That is a morphological disorders which may lead to the cancer formation if left untreated. Chronic, what we have in this group, of course, it's a chronic inflammation. Also chronic injury, ulcerative destructive process like ulcer of stomach and duodenum, Barrett's esophagitis, endometrial hyperplasia and dysplasia like results of the excessive hormone stimulation and excessive cell proliferation. Leukoplakia, it's also results of the chronic injury by the infections or physical factors which lead to chronic inflammation more often, and to changing of the cell growth, to changing in the regenerative process. Chronic inflammation. Chronic inflammation leads to dystrophy of the cells, to atrophy of the cells, to fibrosis, sometimes to hyperplasia, and of course to metaplasia. On the right side lower picture you can see the stages of the squamous cell carcinoma of the bronchus formation. In the first picture you can see normal ciliated epithelium of the respiratory tract of the bronchi, which has a lot of layers, but we have cilia on the surface, we have goblet cells, typical, and all in the normal condition. The second picture, which is B, it's due to the chronic inflammation. We have a proliferation of the basal cells, which we named basal cell hyperplasia. The next stage, it's a squamous metaplasia. As you know from the previous topic, squamous metaplasia, that is the changes of the respiratory ciliated epithelium into the squamous one. The next stage of the cancerogenesis, it's dysplasia. This term you also remember from the previous topic. Next stage, it's CIS or cancer in situ. It's a severe dysplasia when we have the all typical features of the cancer grows, but only in the epithelial layer. And the last, what do we see in this slide? It's a squamous cell carcinoma, malignant tumor from the squamous epithelium. Dysplasia. Dysplasia, that is the abnormality of the epithelial growth and differentiation. We have a lot of features of the dysplasia. For example, that is a basal cell hyperplasia, irregularity of the stratification of the epithelial cells, nuclear hyperchromatism or increased amount of the chromatin, and the nucleus becomes more darker than in normal condition. Increased nuclear cytoplasmic ratio. It means that the malignant cells have more bigger nucleus than normal cells. In normal condition, nuclear cytoplasmic ratio it's 1:4, 1:6. In the tumor cells, we have very big nuclei, a small amount of the cytoplasm, and the nuclear cytoplasmic ratio changed to 1:2, 1:1. Then we have increased amount of mitosis. It's maybe normal mitosis increased in the quantity, and formation of the atypical mitosis. It's also features of the dysplasia or cell atypia. Then enlarged nucleoli, changing of the keratinization, loss or reduction of the cellular cohesion, cellular pleomorphism, loss of basal cell polarity, anisocytosis and the coelocytosis. Here you can see process of the oncogenesis on example of the squamous cell carcinoma of the mucous membrane of the tongue and mucous membrane of the oral cavity. On the middle picture you can see the surface of tongue with the whitish color irregular shaped patch. This patch we named leukoplakia. As you remember, that is a subtype of the parenchymatose or intracellular proteinose degeneration characterized by the excessive accumulation of the keratin material in the keratinized epithelium, and leukoplakia separately, that is a keratinization of the non-keratinized epithelium. And what do we have? These two patients, man 40 years old, they have a cancer of the buccal mucosa in the first picture, in the upper picture, and the cancer, squamous cell carcinoma, in the tongue surface. This man chewing the gum with a betel nut, and it leads to prolonged injury of the mucosa of the oral cavity. The prolonged injury leads to inflammation. Inflammation leads to leukoplakia, first of all. Then it leads to dysplastic changes, to dysplasia of the mucosa, and then it's finished by the cancer. But also sometimes tumors may form de novo from the gene control situation, gene control abnormalities. It's named obligatory precancer states. It's a situation which finished by the growth of tumor without any exception. One day the tumor will grow. Neurofibromatosis type 1 or Reckling-Gausen disease, that is a disorder caused by the mutation of the gene in chromosome 17 that is responsible for the control of cell division. NF1 gene is a development syndrome caused by germline mutation in neurofibromin, and gene that is involved is the RAS pathway. Common symptoms of the Recklinghausen disease include brownish red spots in the color part of the eye called leash nodule, benign skin tumors called neurofibromas, larger benign tumor of the nerves called plexiform neurofibromas, scoliosis, learning disabilities, vision disorders, mental disabilities, multiple capillary spots, and epilepsy. All these symptoms grow from the gene abnormality. One more obligatory precancer, that is a familial adenomatous polyposis. That is a situation when a lot of polyps grows in the large intestine, and these polyps tend to malignize. Malignancy in a diffuse familial polyposis reach 100%. Polyp malignization can occur in any age, but up to the age of 40, colon cancer develops in 100 of cases if prophylactic colectomy has not been performed. In the first blue picture, you can see the fragment of the large intestine, which was removed from the abdominal cavity of the young lady, 25 years old, like a prophylactic of the colonic cancer, because she has a lot of polyps in her large intestine, and her father died because of the colonic cancer, because he and she has the typical mutation which lead to the familial adenomatous polyposis. Next, it's BRCA and BRCA1 and BRCA2 gene mutation. BRCA1 and BRCA2 are human genes that produce tumor suppressor proteins. These proteins helps repair damaged DNA and therefore play a role in the injuring of the stability of each cell's genetic material. Specific inherited mutation in BRCA1 and BRCA2 most notably increase the risk of female breast and ovarian cancer, but they have also been associated with increased risk of the several additional types of cancer, like a prostatic cancer in a man. Gross appearance of the tumor. Tumor may be different in size, in shape, and color. Sometimes it looks like yellow color, oval shaped, shiny nodule, or it's maybe a cystic formation, or it's maybe regular shape tissue which deform organ, or it may be multiple nodules. It may contain mucus inside, or it may be homogeneous on the cross section. In the upper picture with the green background, you can see the part of the large intestine with the multiple polyps, and in some of these polyps we can see growth of the adenocarcinoma, which is epithelial cancer. On the right upper picture, you can see fibroma of the ovary, just oval shape, nodule, dense consistency, pale brownish color, and homogeneous on the cross section. On the lower right picture, we can see mucinous cyst adenocarcinoma of the ovary, and it consists of multiple cavities, and this cavity contain mucus inside. In the left lower picture, you can see mastectomy fragment. It's a result of operation of mastectomy, part of the breast with a big tumor in the upper lateral quadrant, which spread to lower quadrant. Very often in tumor may form secondary changes. Secondary changes associated with the abnormality of the gamma dynamic system of the tumor, and of course inflammative process in the tumor also, because our immune system try to control tumor growth, try to kill tumor cells, and in this case in the tumor forms area of necrosis. So secondary changes, that is a hyalinosis, necrosis, hemorrhage, formation of cyst after previous necrosis and hemorrhages, calcification is also results of the previous necrosis or hemorrhages, ulceration, myxoid changes, etc. Microscopically, each tumor consists of two main components, stroma and the parenchyma. Depending on the development of the stroma, organoid and histioid tumors are distinguished. Organoid tumors have a parenchyma and develop stroma. At the same time, the degree of development of the stroma can be different, from narrow, rare fibrous layer and vessels of the capillary type in the medullary cancer to wide fields of the fibrous tissue with the barely distinguishable chains of epithelial tumor cells in the fibrous cancer, which we also name SCIR. Histioid tumor, the parenchyma predominates. The stroma is practically absent, seeing it is represented only by the thin wall capillaries necessary for their nutrition. Tumors of connective tissue are built according to the histioid type. In this picture, you can see features of the desmoplasia. Desmoplasia, that is a process of excessive growth of the connective tissue. In the case of the diffuse cancer of stomach, which leads to severe desmoplasia, we name this type of cancer rhinitis plastica or sclerous fibrous cancer. In this tumor, in this case, we can see that the wall of stomach increases thickness, becomes very, very dense. The wrinkles of the mucosa is disappear, and on the cross section of the wall of stomach we can see growth of the dense cartilage-like tissue. This cartilage-like tissue, it's a connective tissue. In this case, stomach look like a laser bottle. Atypism. It's a set of characteristic features that distinguish tumor tissue from normal and constitute the biological characteristic of the tumor growth. Kinds. It's maybe morphological atypia, which is classified into the tissue and cellular, metabolic, immunological, biochemical, histochemical, and a lot of other. For us, more interesting is morphological atypia, of course. So we will talk about the tissue atypia and the cellular atypia. Tissue atypia is characterized by the violation of the shape and size of morphological structures, a violation of the ratios of the stroma and parenchyma, and disorderly arrangement of the fibrous structures. In this picture shows lipoma. Lipoma is a benign tumor from the fat tissue. Lipoma consists of the lobules of the mature adipocytes. These cells, it's the same cells that the normal adipose tissue cells, normal adipocytes. We just can see local increase of the amount of the cells, which form lobule separated from other tissue by the false capsules. It's like a lobulated mass. Cellular atypia. The property of the malignant tumor cells leading to the loss of these cells of their initial tissue specificity. A sharp decrease in the ability to adhesion. The formation of the malignant tumor and their acquisition of the ability to constant and controlled growth and reproduction, to metastasis, and sharply distinguishes each individual malignant cell from the normal cell. What are the features of the cell atypia? The same like features of the dysplasia. So features of atypia we can see in the dysplasia and in the tumor, but dysplasia it's like initial stage when we can see the changes only in the half of the epithelial layer or 1/3 of it. But when we talk about the malignant tumor, it's in the all tumors. So signs: cell polymorphism, hyperchromatism of the nuclei, polyploidy, changing in the nucleus cytoplasmic ratio. As we said before, it's changed to 1:1, 1:2. High mitotic activity with the presence of atypical mitosis. In the right side picture you can see the butterfly-like atypical mitosis. Rate of tumor differentiation. What is a tumor differentiation? Differentiation of tumor, it's a resemblance of the tumor cells to the normal cells. If the tumor tissue, tumor cells look the same that the normal tissue, in this case we talk about well-differentiated tumor. When the tumor cells is not resemblant, so it's a poorly differentiated or non-differentiated tumor. Differentiation of that tumor associated with the malignant potential or grade of malignancy of the tumor. A well-differentiated tumor has grade 1 or grade 0 malignant potential, so it's a low-grade tumor. Poor differentiated tumor or non-differentiated tumor, it's a high-grade tumor, so it has very high proliferative activity, it grows faster and metastasizes very fast. On this picture you can see moderate differentiated or intermediate grade tumor, which consists of the tubular-like structures with some mucus inside. And here you can see undifferentiated tumor. Undifferentiated tumor consists of the cells which has no any specific appearance, so we can't understand from where these cells, from what tissue this tumor grows. Type of the tumor growth, now we will talk about that. Type of tumor growth depend on the degree of differentiation. It's maybe expansive, oppositional, and infiltrative. Expansive type of the growth character for the benign tumor. In this case, tumor grows from itself. It's just enlarged in size and compress surrounding tissue, but do not destroy it. In invasive type of the growth, tumor ingrows into the surrounding tissue and destroy it. In the left side picture you can see the whitish color, it's a tumor tissue, and the red color, it's a lung tissue. So as you see here, tumor from the bronchial epithelium, we also name it lung cancer, bronchogenic carcinoma, it ingrows into the lung tissue and leads to the totally destruction of it. Tumor growth depending on the lumen of the hollow organs. It's maybe endophytic and exophytic. Endophytic type of the growth, it's when the tumor grows into the wall of the hollow organ. In these two pictures you can see adenocarcinoma of the rectum. This tumor starts growth from the epithelium of the mucosa of the rectum, and then it grows deeper into the subepithelial layers, into the muscular layer and into the fatty tissue. Exophytic growth, it's when the tumor grows into the lumen of the whole organ. Next variant of the tumor grows depending on the number of the primary foci. It can be unicentric and multicentric. Unicentric is when we have a single nodus of the tumor growth. Multicentric, it's a multi-focal type of the growth, when we have a lot of primary foci of the tumors. It's not a metastasis, it's a primary foci. In the left picture, you can see the multicentric growth of the adenocarcinoma of the lung. It's a rare variant of the lung cancer, which is associated with KRAS mutation, and it's more character for non-smoking ladies. Now we will talk about the metastasis. What is it? Metastatic growth is a process of formation of the secondary foci of the tumor growth. Metastasis as a result of the spread of cells from the primary focus to other tissue. Routes of metastasis. It's maybe transcelomic variants of the spreading. The spread of malignancy into the body cavities can occur via the penetration of the surface of the peritoneal, pleural, pericardial, or subarachnoidal spaces. More often, it's variant of metastasization character for the malignant tumor of the ovary. In this case, ovarian tumor can spread transperitoneally to the surface of the liver. Lymphatic spread or lymphogenic route. A lymphatic spread allows the transfer of the tumor cells to regional lymph nodes near the primary tumor and ultimately to another part of the body. This is called nodular involvement or positive lymph node or regional disease. Lymphatic spread is the most common route of initial metastasis for the carcinomas. Carcinomas is a malignant tumor of the epithelial region. Next, hematogenous spread. This is a typical route of metastasis for sarcomas through the bloodstream. Canalicular spread. Some tumors, especially carcinomas, may metastasize along the anatomical canalicular spaces. These spaces include, for example, the bile ducts, urinary system, and the airways, and the subarachnoid space. In the pictures, in the left picture, you can see typical metastasis which spread through the lymphatic vessels. This is the emboli, typical tissue or tumor emboli in the lymphatic vessels. In the right picture, you can see spreading of the prostate cancer through the perineural spaces. So in the center we can see nerves and tumor cells which localize in the perineural space. Stages of the metastatic growth. Intravasation. There is a penetration of the tumor cell in the lumen of the blood or lymphatic vessels. Dissemination. Tumor cells are carried out by the blood or lymph through the body. The embolism. It's when the tumor cells stop at a new location. And extravasation. There is a release of tumor cells into the perivascular tissue. And the last is the formation and growth of the metastasis. Only one cell, tumor cell from 1,000 cells which pass to the bloodstream survive and give the rise for the metastasis. On this picture you can see metastasis of the sarcoma and carcinoma in the lung and in the liver. It's a CT scan and gross macro preparation with the presence of the nodular masses in the liver, multiple nodular masses in the liver and in the lung. Metastasis more often is bigger in size than the primary tumor. It's a lot, it's multiple in the quantity, and it grows faster. In the center of the metastasis, we can see a lot of secondary changes like cavities, like necrosis or hemorrhages, etc. And also, more often, the primary cancer has irregular shape, but metastases tend to be oval or round, and only in the deep stages it's transformed to the irregular mass. Now we will talk about TNM classification of the malignant tumor. This classification of the malignant neoplasm was devised by Pierre Denoy in the middle of the previous century. The practice of dividing malignant neoplasm into the groups according to the stages is based on the fact that the patient's survival was high in the cases where the tumor was local and the tumor did not spread outside the affected organ. Aims of TNM classification: it's a treatment planning and counting of the prognostic factors, evaluation of the treatment results, exchange of information between the different medical centers, studying of malignant neoplasm, and control of the malignant neoplasm. TNM is a notation system that describes the stage of the cancer which originates from the solid tumor using alphanumeric codes. T describes the size of the original or primary tumor and whether it has invaded nearby tissue. N describes nearby or regional lymph nodes that are involved. M describes distant metastasis, spread of the cancer from the one part of the body to another, like metastasis into the liver or metastasis into the lung. Basic classification: it can be pathological and clinical. Clinical classification, a pre-treatment classification that is used to select and evaluate the effectiveness of the treatment. It is based on the pre-treatment symptoms like CT scan, ultrasound, palpation, etc. Pathomorphological classification or pathological classification, PTNM, it's a classification after surgery for the choice of additional therapy. For more information about the prognosis of treatment as well as for statistical recording of the treatment results. The morphological assessment of the prevalence of the primary tumor, category PT, is performed after resection or biopsy of the neoplasm. Regional lymph node involvement, category PN, is assessed after removal. In this case, the absence of metastasis is designated as PN0, and the presence is denoted by the one or another PN value, PN1 or PN2. The presence of the distant metastasis is determined by the microscopic examination. After determining the categories of T, N, and M, or PTNM, and they are grouped into one or another stage of the disease. The established TNM categories as well as the stage of the disease should remain unchanged in the medical records. Clinical and pathological classification data can be combined in cases where the information present in them complements each other. Now I want to show you the case from the practice. Woman, 47 years old, has a complaint of the abdominal and lower back pain. Under the ultrasound was found multiple nodules in her abdominal cavity in the omentum. During laparoscopic examination, this material was received from this formation, from these nodules, and undergo histological examination. On the histological examination, we are found multiple foci of the growth of the malignant tumor adenocarcinoma grade 2 with necrosis and inflammation, but we understand that is a metastasis. It's not a primary tumor. So we must know from where these metastases start. What was the primary focus for this tumor? And for that, we use immunohistochemistry. Immunohistochemical procedure includes several steps for the more correct investigative process. Step 1, when we separate all tumors which is possible in our body into the four main groups. It may be epithelial tumor origin, it may be a tumor from the lymphoid tissue, tumor from the nervous tissue, and mesenchymal tumors. So pancytokeratin will be positive only in the cells which has epithelial origin. CD45 positive only for the lymphogenic cells. S100 it's a marker of the nervous cells, and vimentin it's a marker of the mesenchymal origin. Step 2, when we received this tumor is epithelial, so pancytokeratin was positive, we added cytokeratin 7 and cytokeratin 20. In this case, we have a situation when the cytokeratin 7 was positive and cytokeratin 20 is negative. And with the help of this step, we also divided a lot of tissues into the four categories. We received only one group of the tumors, which can be. As you see in this picture, it may be endometrial adenocarcinoma, ovarian serous carcinoma, ovarian clear cell carcinoma, salivary duct, thyroid, and the cervical, pancreatic, stomach, and breast adenocarcinoma, or lung adenocarcinoma. All these cancer give the positive reaction with the cytokeratin 7 and negative for the cytokeratin 20. So our next step was adding of the estrogen, TD1, CDX2, WT1, and CA125 and PAX-A. For what? Estrogen will be positive only in the cells which has receptor for them, so it's only breast or genital organs. TDF1 will be positive if these tumors grow from the lung or thyroid. In our case, this marker was negative. CDX2, it will be positive for colon, bladder, stomach, and endometrium. In this case, it was negative for CDX2. So it's not a colon, it's not a bladder, it's not a stomach, endometrium, or lung or thyroid. WT1 normally positive for the serous carcinoma of the ovarian origin, and in our case it was positive, so we have positive estrogen and WT1. CA125 normally positive for the carcinoma of the biliary tree, breast, cervix, endometrium, fallopian tube, liver, lung, ovary, serous, but also pancreas and ovarian sex cord tumors. In our case, it was positive. And PAX-8, it's a positive in ovarian carcinoma, all type except mucinous variants. So our conclusion was that is a metastasis of the high-grade serous ovarian cancer. Now we turn to the epithelial tumor discussion. Epithelial tumor, this may grow from the squamous or transitional epithelium or prismatic or glandular epithelium. It may be benign and malignant. If it's benign, we name it papilloma when it grows from the squamous or transitional epithelium, or adenoma when it's from the glandular one. Malignant variants, squamous or transitional cell carcinoma and adenocarcinoma, it's a malignant tumor from the glandular epithelium. Papilloma. Papilloma, it's a very frequent tumor which look like a nodular mass on the thin peduncle or in the white base. It has exophytic type of the growth. It's a benign epithelial tumors, more often it's localized on the skin or a mucous membrane. It grows slowly, it's maybe hard and soft. Hard papillomas, it's a skin and mucous membrane covered by the squamous epithelium. So it's a tumor which composed of the squamous epithelium. Soft papillomas forms in the more often in the urinary tract. It's covered by the transitional epithelium. In this case, it's not good prognosis because papilloma, soft papillomas or transitional cell papilloma grows faster. Here you can see the typical skin hard papilloma, tree-like structure covered by the squamous epithelium. Adenoma, a tumor of glandular tissue and mucous membrane lined by the prismatic epithelium. Adenoma is a mature benign tumor from the glandular epithelium. It grows expansively. Macroscopically, it looks like a well-delimited node of soft elastic consistency, pinkish white in color. Sometimes it contains cyst, and in this case we name it cyst adenoma. The size of the adenoma may be different from several millimeter to centimeters, 20-30 centimeter in diameter. Adenomas which we are found in the mucous membrane, for example in the gastrointestinal tract or uterus, which protrude above the surface of the mucosa, we name adenomatous or glandular polyp. Morphological variants of adenoma. It's maybe acinar, which look like acinus, tubular, which forms structures resemble to tubes, trabecular, like in the liver, trabecle solid, papillary cyst adenoma, villous adenoma or fibroadenoma, and a lot of other variants. Now turn to microscopic form of the cancer. The basic types, it's a carcinoma in situ, squamous cell carcinomas with keratinization or without keratinization, and adenocarcinoma, and a lot of other variants like adenoacanthoma, solid or trabecular cancer, medullary carcinoma, mucous carcinoma, colloid cancer, small cell carcinoma, old cell carcinoma, etc. Carcinoma in situ. Carcinoma in situ or intraepithelial variant of the cancer. It's the initial stage of the malignant tumor growth when we can see all features of the malignant growth, but only in the epithelial layer. So malignant tumor cells do not penetrate, in this case, basal membranes, so we know that this tumor is not metastasized. It's just only in the epithelium. Of course, it's not good because it's a tumor, it's a malignant tumor, but for the prognosis, it's more better than when we can see invasive type of the cancer. Squamous cell carcinoma may be with keratinization or without keratinization. Differentiated cancer from the integumentary epithelium grows into underlying tissue and destroys them. The tendency toward cell maturation and keratinization persists. On the periphery of the complex cells are less differentiated, rounded, with a narrow rim of the cytoplasm and hypochromatic nuclei. In the center, they are flat, light, containing hyaline in excess, with pronounced keratinization, horny masses accumulate in the center of the complexes in the form of bright pink concentric formation. These clusters are called crayfish pearls or cancer pearls, differs in relatively slow growth. Keratinizing squamous cell carcinoma developed in the skin in the mucous membrane covered with a flat or transitional epithelium, in the oral cavity, esophagus, cervix, vagina, etc. In the mucous membrane covered with a prismatic epithelium, squamous cell carcinoma develops only after previous metaplasia and epithelial metaplasia. Canceromatous pearls. Adenocarcinoma, an immature malignant tumor from the prismatic epithelium which forms glandular structures of various shapes and size, growing into the surrounding tissue and destroy them. Found in mucous membranes and glandular organs. Cellular atypism is sharply increased, or which manifested itself in the cell's polymorphism, nuclear hyperchromatism. The basement membrane of the glands is destroyed. The glands can be formed by the multi-row epithelium, but their lumens is always preserved. Sometimes the lumen of the glands is enlarged and there are papillary protrusion in them. This is papillary or papillary adenocarcinoma. They also distinguish between the acine and tubular adenocarcinoma. Adenocarcinoma has a different degree of differentiation which can determine its clinical course and prognosis. Adenomas of the endocrine glands may be hormonally active, produce hormones, or non-active. Apodomas, term given to the embryonologically related group of tumors of endocrine organ. Apod system, you know it, amine precursor uptake and decarboxylation system. Apod cells share properties of both neural and endocrine tissues, i.e., neuroendocrine cells. Tumor of these systems named apodomas. It's produce hormones, and we are including this group carcinoid adenomas of the endocrine glands like the pancreas, pituitary gland, and epiphysis, and the paragangliomas. Carcinoid, tumor of enterochromaffin cells that produce biogenic amines like serotonin. Most often found in the appendix, may lead to carcinoid syndrome. What is it? Carcinoid syndrome associated with the redness of the skin, watery diarrhea, bronchospasm, non-infectious thrombotic endocarditis of the right half of the heart. Carcinoid may be benign and malignant, may give the metastasis. Sometimes we also call atypical carcinoid. It's all connected with the proliferative activity of the cells which give the origin for this tumor. Cancer of the stomach. Cancer of the stomach is more than 1 million cases per year. More often, the sick person is elderly man, 40, 60 years old. We have some risk factors which may be classified into the exogenous and endogenous. Exogenous risk factors include high salt diet, prevalence of the carbohydrates in food, cigarette smoking, low vegetable containing diet. Endogenous factors, it's duodenal reflux, some genetic immunological factors. More often, cancer forms in the pyloric area and on the last curvature. Precancerous condition which lead to the stomach cancer, that is a pernicious anemia which is associated with atrophic gastritis, presence of the gastric stump, intestinal metaplasia which is also associated with the chronic gastritis, and gastric atrophy of the mucosa of the stomach, and epithelial dysplasia. Early gastric carcinoma. It's a carcinoma limited to the mucosa alone or mucosa and submucosa. Microscopically, we have three variants of the gastric carcinoma. It's a protruded, superficial, and excavated. Superficial may be elevated or flat or depressed. Microscopically, the most early carcinomas remained intramucosal until they exceed 3 millimeters. Invasion of the submucosa is through breaches in the muscularis mucosa associated with the lymphoid aggregates. Advanced gastric cancer. It's a cancer extending beyond the muscularis propria. Location. As I said before, it's a prepyloric region, pyloric antrum, and less curvature. Macroscopically, we have a lot of variants, but generally three main: ulcerating, nodular fungating, and infiltrating, which is lenitis plastica or laser bottle stomach or diffuse variant. Microscopically, the most widely used classification of the Lauren, it's two types. It's intestinal variant of the cancer and diffuse variant of the cancer. Spreading of the tumor. Tumor may spread by the direct invasion, lymphogenically to the regional lymph nodes of the less curvature and a big curvature according to localization of the tumor. Hematogenic, spreading into the lung, liver, ovaries, and adrenals. And transperitoneal, about 25% of cases which lead to the involvement of serous cord. In this case, we can see bilateral ovarian metastasis, which we named Krukenbeck tumors, metastasis to the pararectal tissue, which we named Schnitzler metastasis. Also, additional variants of the retrograde metastasis, it's a metastasis of the into the left intraclavicular lymph nodes, which named Virchow node or Virchow metastasis, and metastasis into the umbilical region named Sister Mary Joseph metastasis. Cancer of the lung. The main etiological factors which lead to the cancer of lung is cigarette smoking, molecular changes, and chromosomal deletion. Depending on location, we are classified it into the basal, central, and peripheral. Central variant of the lung cancer grows from the trunk lobe and initial part of the segmental bronchus. Peripheral grows from the peripheral segment of the segmental bronchus and its small branches, as well as from the alveolar epithelium. More often, peripheral cancer, it's a non-small cell carcinoma, but adenocarcinoma. Here you can see classification of the lung cancer. Lung cancer, first of all, classified into the small cell carcinoma and non-small cell carcinoma. Small cell carcinoma include pure small cell lung carcinoma, combined small cell and non-small cell lung carcinoma. Non-small cell carcinoma include adenocarcinoma, large cell carcinoma, squamous cell carcinoma, a lot of variants. More often variant, it's squamous cell carcinoma associated with smoking. Adenocarcinoma, it's a variant of the peripheral cancer more often for non-smoking patient. Different histological subtypes may have different rates of malignancy. Clinical features of the lung cancer, it's a cough, hemoptysis, airway obstruction, and chest pain. Spread to the adjacent structure like pleural nerves, involvement of the sympathetic plexus leads to additional symptoms like Horner syndrome. Horner syndrome, it's a unilateral constriction of the pupil, ptosis, anaphthalmos, and loss of sweating on the injured part. In the case of the compression of the mediastinum, we can see syndrome of vena cava superior. Chest pain also maybe, and when it grows to the pericum, we may see the problems with the heart. Paraneoplastic syndromes associated with weight loss, loss of appetite, disseminative intravascular coagulation, clubbing, Cushing syndrome, and hypercalcemia. Squamous cell carcinoma. bronchoscopy may show an exophytic cauliflower-like mass. Growth into the airways cause obstruction with the collapse of the distal segments associated with infection, bronchiectasis, and pneumonia. Microscopically, we can see islands of the cells, sometimes showing keratinization, if it's keratinized squamous cell carcinoma, of course. Small cell carcinoma. It's aggressive behavior with early dissemination, often associated with a paraneoplastic syndrome. Small to medium-sized cells with a little amount of the cytoplasm. Nucleus packed together, nuclear molding. It's positive for the calcitonin and other neuroendocrine markers. Adenocarcinoma, arise peripherally, has multicentric type of the growth more often. Microscopy shows mucin production or presence of the tubular papillary structure. There are 6 main types of the adenocarcinoma of the lung, maybe papillary, micropapillary, or acinar, etc. Multiple tumor, fever, metastasis. Lung cancer metastasis. In the first phase, lymphatic metastasis affect the pulmonary lymph nodes in place of division of the lobus bronchus to segmental. Hematogenous metastasis, mainly in the liver, brain, bone, adrenal. In connection with the necrosis, cavity formation, bleeding, separation forms in the tumor, which lead to the pneumonia, of course. Cause of death, it's a metastasis, secondary pulmonary complication, and cachexia. Thyroid cancer. It's a malignant tumor from the follicular or from the C cells. Etiology. Exposure to ionizing radiation, presence of neoplastic process in the thyroid tissue, hereditary syndromes, and mutation. Follicular and papillary thyroid cancer are attributed to highly differentiated forms. Medullary carcinoma is more aggressive, early metastasizes to regional lymph nodes of the neck. Histological classification of the thyroid carcinoma has 6 main variants. It's a papillary, follicular, medullary, hereditary, poor differentiated, and undifferentiated. Papillary cancer. According to the WHO classification, there are 15 variants of the papillary thyroid carcinoma, including prototypical, common, or classic papillary thyroid carcinoma. The predominant form of thyroid carcinoma, accounting for 93% in modern research. It occurs in children and adults, more often in the age of 30-40 years old, more often in women. Histologically, papillary and glandular structure are covered with one or more layers of cubic or prismatic cells with a hypochromatic or light nuclei. Metastasis to the cervical lymph nodes and lungs. The most common type of thyroid carcinoma, in which is defined by the set of distinguished nuclear features, including changing in the size and shape of nuclei. We can see in the case of papillary carcinoma enlargement, elongation, and layering of the nuclei, chromatin changes like chromatin clearing, margination, vitreous nuclei, nuclear membrane changes like irregular contour of nuclei, nuclear grooves, and nuclear false inclusion or pseudo-inclusion. Follicular cancer. Thyroid carcinoma with a follicular differentiation but without signs of papillary nuclei. Includes 6-10% of thyroid carcinoma. Iodine deficiency is a risk factor, usually single cold nodule on radionuclide scanning. It occurs in adults more often at the age of 50-60 years old. It's characterized by the slow growth. The course is more aggressive than in the papillary cancer, often metastasis to the lymph node of the neck and less often distant metastasis to the bones, lungs, and other organs. Characterized by the slow growth, more aggressive than papillary cancer. Medullary carcinoma. Neoplasm making up to 5–10% of thyroid malignant tumor. A neuroendocrine tumor originated from the C cells, formerly called parafollicular cells, and of the ultimobranchial body of the neural crest, which secrete calcitonin. So in this cancer we can see increased level of the calcitonin. Consists of the fusiform, rounded, polygonal cells arranged in the form of strands, fields, and complexes surrounded by the loose stroma. Usually, a homogeneous hyaline-like substance of amyloid is located between the dense cell layers. A highly aggressive malignant tumor represented by the undifferentiated cells of epithelial region named anaplastic cancer. It often develops against the background of the long-standing nodular goiter. It is atypical for elderly. It grows rapidly and it grows into surrounding organs, quickly gives the distant metastasis. The duration of the course of the disease is about 1 year. Microscopically, it's characterized by the varying cells types, and sometimes has sarcomatose appearance. Study of the immunophenotype is associated with the difficulties in establishing the epithelial cell region of the tumor, but the absence of expression of cytokine still does not exclude anaplastic carcinoma. Immune expression of thyroglobulin and TD1 is often absent. PAX8 expression can only be established in half of the cases. Thank you for your attention.